Good afternoon to everyone. Good morning and good evening. It depends on where you are. It's a great pleasure and honor to introduce Dr. Marc Pusztaszeri on today's International Academy of Cytology webinar. He will talk about ancillary techniques and salivary gland cytopathology and scoping also on the role of cell blocks. Dr. Marc Pusztaszeri is currently Associate Professor at the Department of Pathology at the Jewish General Hospital and McGill University in Canada. He is an expert on salivary gland cytopathology. He is involved in several terminologies on head and neck area cytopathology, including the newest WHO classification, but he's also co-author in the Milan and Bethesda terminologies. Marc, podium is yours.
Thank you very much, Ivana, for the nice introduction and for the invitation. Hello, everyone, and greeting from Canada, Montreal. It's a great pleasure to give this talk on optimizing salivary gland FNA diagnosis, and I will discuss the role of cell block and ancillary studies. I have nothing to declare. This is the educational objective again. Please note that molecular testing and NGS will be covered in greater detail in a future webinar next month. So as you well know very well, cytomorphology alone is usually sufficient to recognize the most common neoplasms, including pleomorphic adenoma, Warthin tumor, and high-grade carcinomas. And furthermore, the Milan System and the risk categorization for salivary gland FNA are sufficient to guide the management in most cases. So ancillary studies for salivary gland FNAs are actually needed in only a minor subset of cases. You should now be very familiar with the Milan System and the different diagnostic categories which are associated with different risk of malignancies, and also a recommendation for management. In 2021, the ASCO guidelines has recommended several recommendations for the management of patients with salivary gland malignancy, and they endorsed the FNA biopsy and also the risk stratification scheme by the Milan System. And you can see here more in details the recommendation. They suggest that the provider can perform either a FNA or a core needle biopsy to support the diagnosis of salivary gland lesions. They may perform a core needle biopsy if FNA is inadequate, or if it's a difficult site, such as a deep minor salivary glands, and they emphasize that pathologists should report the risk of malignancy by using a risk stratification scheme, such as the Milan System. And also they recommend that pathologists may perform ancillary testing, immunohistochemical or molecular studies on those type of biopsies to support the diagnosis and the risk of malignancy. So if you compare both FNA and core needle biopsies, as you know, both of them, unfortunately, the major limitation is the inability to assess for invasion, which is a key feature to diagnose several subtypes of malignancy in the salivary gland, just like for the thyroid malignancies. And you can see here the main advantages and disadvantages of both techniques. So for the FNA, one of the main advantage is that it is also amenable to rapid on-site evaluation, in contrast to core needle biopsy. But on the other hand, one of the limitation of FNA is that the material is often limited for ancillary studies, whereas the core needle biopsy often provides a very good material for ancillary studies. And we will discuss this later on. And we can ask ourselves, is there actually something that is in between? As we can see, for example, in the AUS fine needle biopsy of the pancreas, we'll talk about that later on as well. Because the Milan system has been so successful as applied to FNA specimens, several institutions have tried to apply also successfully Milan system-like categories to core needle biopsies, and they have shown that it is also extremely valuable as it helps to standardize the reporting and to guide the management for core needle biopsies as well. So when do we actually need ancillary studies? So we can actually consider ancillary studies to resolve diagnostic uncertainty, or to change the Milan system category and improve the risk stratification, and finally also to help guide the clinical management and the surgery planning. So it will be mainly for the categories between 3 and 6. And you can see here this algorithm that's already from this paper already several years ago, that's very helpful to help you decide when ancillary studies might be beneficial or not. You can see that one of the problems is with this category AUS, one of the issues is that often the material is too scant to be amenable to ancillary studies. And on the other hand, for this category, neoplasm benign, neoplasm suspicious for malignancy and malignant, whenever you can, a more specific diagnosis could be beneficial for the clinical management. This is when ancillary studies would be very beneficial. Whereas if it's not gonna change really the clinical management, the ancillary studies testing are rather optional and will depend on the availability and what is can be done at a specific institution. When we did the preparation of the Milan system, we did a survey of the cytopathology community and their practices at large, which gave us very useful information, including how they perform ancillary studies. And you can see here the main indication to perform ancillary studies, including basaloid neoplasms, oncocytic neoplasms, but also metastatic lesions, or to rule out lymphoma, especially with flow cytometry, or to subtype different types of high-grade or low-grade carcinomas. And you can see here that the vast majority of participants used immunocytochemistry or even flow cytometry, whereas FISH or NGS was much less commonly used. But this is already about 8 or 9 years ago. So those numbers could be nowadays slightly different. And you can see also this is very important that the vast majority of participants used cell block preparation as opposed to liquid-based or conventional smears to perform ancillary studies. So the cell block was really the most common source of material for ancillary studies testing. Also, it's very important to keep in mind that in order to perform ancillary studies, adequate material and also appropriate validation are both essential, and rapid on-site evaluation is very helpful to help triage cases and material adequately for the ancillary studies. I will get back into that very soon. And also, again, cell blocks, ideally formalin fixed, can be a very ideal platform to perform all the ancillary studies, especially the immunohistochemical panels, but also the other ancillary studies like FISH and NGS. Rapid on-site evaluation can be very beneficial, and somehow there's only a limited number of studies that have been published for the head and neck and salivary gland. You can see here an algorithm that can be quite helpful from this paper. After a rapid on-site evaluation, the specimen can be roughly classified into one of the Milan System category. And for example, if it's non-neoplastic or benign, then the patient can already have a clinical management. Whereas if it's a non-diagnostic AUS or indeterminate or even malignant, those cases can be triage for cell block or additional passes for flow cytometry to help triage the specimens for the different ancillary studies. This is one of the studies that have shown that during a rapid on-site evaluation, the material could be triaged based on the Milan category assigned for the different techniques and also for microbiology. And the allocation to the Milan categories during rows was also very helpful for cases that required rapid clinical intervention, such as the planning and the extent of the surgical procedure. So here you can see some of their examples from these studies. On the top left is acute salivinitis. Next is granulomatous salivinitis. So for those cases, they can be a triage for microbiology. And other example is a pleomorphic adenoma, warting tumor, mucoepidermoid carcinoma. If the diagnostic is clear, there's no really need to do ancillary studies. But for example, on the bottom right, if you diagnose a high-grade carcinoma during the rapid on-site evaluation, this is a good case to do additional passes for a cell block preparation to anticipate immunohistochemistry, for example, to distinguish or to rule out the possibility of a metastasis, because the management would obviously be very different for these patients. The problem with flows is that it also comes with several limitations, including, as you can expect, the resource and the time intensive. It requires personal availability. It adds workload. It requires the skilled cytopathologist and or trained cytotechnologist. There is technical variability and also a limited diagnostic accuracy. Rapid on-site rapid rows is not always available, depending on the logistics and the different institutional preferences. So why do cell block matter for salivary gland cytology? One of the problems is that the cell blocks, unfortunately, they are not routinely prepared in all cases, because oftentimes those samples are prioritized for smears and liquid-based cytology. And when they are prepared, they are often acellular or post-cellular and insufficient for ancillary studies. And this has been shown and discussed in several papers. And also, one aspect is that the size of the needle that is used for aspiration can also play a role for the cellularity of the cell blocks. You can see here the pros and cons of the different cytological preparation. So one of the main advantages of the cell block is that it allows to perform all the ancillary studies without the need for additional validation. So they are really an ideal platform to perform not only IHC, but also FISH and NGS. Whereas on the other hand, all the other cytological samples are also suitable for those techniques. but they require a specific validation. And actually, there is updated guidelines from the College of American Pathologists that re-emphasize this aspect, stating that for analytic validation of IHC performed on cytologic specimens that are not fixed in the same manner as tissues used for initial assay validation, the labs should perform separate validation for every new analyte and corresponding fixation before using them for clinical use. And this applies to technically all types of cytologic specimens, including even alcohol-fixed cell blocks and liquid-based cytology, air-dried smears or alcohol-fixed smears. And they recommend a minimum of 10 positive and 10 negative cases for each validation. And one of the problems that you can expect is, for example, if you want to validate a new antibody for a malignancy that is not so common in the salivary gland, like a secretory carcinoma or even acinic cell carcinoma, it might take quite some time to validate a new antibody on these different types of preparations. So this is really because those different fixatives that we use in cytology definitely impact the sensitivity of the assay, and anything that is exposed to a fixative others that what is used for the initial assay should be separately validated and verified. So this is from the latest edition of the Milan System, the second edition, where they suggest that ideally the FNA should utilize a 23 or 25 gauge needle, and in general cell blocks they complement the direct smears, air dried and alcohol fixed, and the LBC, but they do not typically not typically used as a sole diagnostic modality, but rather they are reserved for selected cases where IHC or molecular testing would be required. So what we have been doing in my hospital since I came here, or even before that, is that the surgeon use very large 21G needles with ultrasound guided FNAs, and this material is directly converted into a formalin fixed paraffin embedded cell blocks with the histogel techniques. So this is already optimized for the use of immunohistochemistry and does not require, again, separate validation. And with this technique, we have obtained very good results. So you can see here, this is the typical gauge that is used at our institution. The material is collected in SynPrep vials, but it is methanol-based, which again is not that would require again a separate validation, as we have discussed before. So they also obtain very good results with this technique, and the rationale is that they really want to optimize the use of samples that are cell poor for morphology and ancillary studies. And it also helps to streamline the workflow in their lab. This is just another study that showed that the use of immunohistochemistry on the salient cell block, however, can be problematic because the results are not optimal. And again, just to emphasize that it really requires separate validation to use because the immunoreactivity might be lost for some of the antibodies. And this is another study that have also used small tissue biopsy combined with cytological smears. They were during the ultrasound guided FNAs, and they have used this type of needle, which is also a 21 gauge, but modified manganese type of needle. And I can show you here, this is some of their cases. So you can see, for example, this case here on the left, you don't see very well, but this is a case where it would have been classified as a sump in the sump category, basaloid neoplasm on the smears. And after the small tissue fragment on the cell block, they better highlight the architecture, and they were able, with the use of immunostains, to upgrade the diagnosis from a sump to a malignant, and it was actually epithelial myoepithelial carcinoma. So this is just to show that there is some analogy with what is being done in the gastrointestinal lesions and pancreatic lesions biopsies, where there is definitely a trend to use larger needles, like the sharp core needles that have been shown to enhance the diagnostic accuracy compared to standard FNA needles in many clinical situations. And they also highlight that those type of needles improved sampling, especially when it is not possible to do a rapid on-site evaluation. And in addition, it allows to obtain a larger volume of tissue that could be obviously very helpful for ancillary studies and molecular testing in a subset of those cases. So you can see here an example of how this material looks like when they use fine needle biopsies as opposed to fine needle aspiration. So it really gives a larger piece of tissue, almost like mini cores biopsies, and this material is very helpful to perform any types of ancillary studies. So now I will review the different type of ancillary studies that we can perform on salivary gland cytology. So before that, it's important to review the current knowledge about the molecular and genetic alteration in salivary gland tumors. So this was in the first edition of the Milan System in 2018. You can see that only a small subset of salivary gland tumor were characterized by specific genetic alterations that can be used as diagnostic markers. But the picture is very different in 2023 or 2025, where you can see that now the vast majority of salivary gland tumor have been characterized by specific genetic alteration, especially gene rearrangement or fusions, which can be also used as diagnostic markers. And there's also new entities that have been described with specific genetic alteration, which we actually rarely encounter on salivary gland FNA, because several of them actually arise more in the minor salivary gland in the oral cavity. So this is the second part of this increasing list of tumors characterized by those genetic alterations. And also importantly, some of those alterations become targetable. So it's not only about diagnosis, it's also becoming helpful for possible management for targeted therapies. But based on that, there's obviously an emerging role of NGS, but this will be discussed more in detail in this upcoming webinar next month by Dr. Niels Roep. But at the same time, there's the immunohistochemistry keeps improving because now we have many more immunomarkers that can be used to narrow down the differential diagnosis and to achieve even a specific diagnosis. And we have several new antibodies that can actually identify protein surrogates of specific genetic alterations that are overexpressed in a subset of salivary gland tumors. In general, those markers are more sensitive but less specific, of course, than the genetic alterations that can be confirmed by either FISH or NGS, depending on the preferences and availabilities in the different centers. So you can see here the markers, immunomarkers that we can use as a surrogate for those genetic alterations. So for pleomorphic adenoma and carcinoma XPA, we have a PLAG1 and HMGA2. For adenoid cystic carcinoma, we have MYB. There's nothing yet for muco-ep carcinoma. For secretory carcinoma, we have a PanTrack along with other antibodies that are less specific, but very useful. For actinic cell carcinoma, we have NOR1, or also called NR4A3. And for epithelial myoepithelial carcinoma, we have a RAS Q61R antibody. And I will show later on some examples of those immunostains. Of course, the use of panels of immunostains is often is much better to increase the sensitivity and the specificity to diagnose those different types of neoplasm. And you can see here the suggested panels that we can use for basaloid salivary gland tumors, or for in the bottom for salivary gland tumors with oncocytic features. So the use of those panels on cell block can be very helpful, and I'll show some example very soon. Also, some salivary gland tumor have a characteristic immunoprofile with diagnostic markers that are not related to defining genetic alteration, and this is an example is the salivary duct carcinoma that typically is positive for androgen receptor and also HER2 along with GATA3. Secretory carcinoma are typically positive for S100 and mammaglobin, and actinic cell carcinoma are typically positive for DOG1. There's also SOX10 that can be used in the panel, but now it has been shown that SOX10 is actually positive in growing list of salivary gland tumors, so it's not so helpful anymore. The only tumors which are usually typically negative would be warting tumor and oncocytic neoplasms such as oncocytoma. And here you can see a useful algorithm that shows for the different types, a subset of sump lesions, including basaloid neoplasms, oncocytic neoplasms, and neoplasm with clear cell features, the differential diagnosis along with the suggested immunohistochemistry panel. And if that's not sufficient for the diagnosis, finally the use of molecular analysis to confirm the diagnosis and to guide the clinical management. So now I will show you some examples from my practice here. So all those cases are again were processed directly as a cell block fixed in formalin. So here you can see a very nice example of typical Warthin tumor. Of course, there's no need to do any ancillary studies in such cases. The diagnostic is straightforward. And also on cell block or your core needle biopsy, one advantages is that you can also see very useful architectural features for the diagnosis, and for the Warthin tumor, that would be the typical bilayered oncocytic epithelium, which is helpful for the diagnosis. This is a typical cases of pleomorphic adenoma. Also, when you have this chondromyxoid matrix and the biphasic nature of the neoplasm that you can highlight with a dual immunostain like CK7 and P63. Those cases are very easy to diagnose as a pleomorphic adenoma. And in some cases, we may use immunostains as a panel, including PLAG1, to confirm the diagnosis. This is a case where you see the typical cribriform architecture with those hyaline globules that is very suggestive of adenoid cystic carcinoma. And you can confirm the diagnosis with again, the use of a panel of stains. And you can see here the strong positivity for MYB that supports the diagnosis. In this case, the tumor was also strongly positive for CD117, but negative for PLAG1. But of course, as you may be aware, the cribriform architecture is not specific of adenoid cystic carcinoma, and it can be seen in other basaloid neoplasms. This is an example of a basal cell adenoma that is very well defined. It's not invasive. It also has this prominent cribriform architecture. And you can highlight the dual, the biphasic nature of the neoplasm with this dual immunostain. And in this case, a common feature of basal cell adenoma, but also a subset of basal cell adenocarcinoma, is that they express beta-catenin in the nuclei of the tumor cells, which is related to the mutation of the beta-catenin gene. So this is also a helpful feature to support the diagnosis, but it would not be entirely entirely specific to distinguish between basal cell adenoma and adenocarcinoma. This is a nice paper that shows that even pleomorphic adenoma can also sometimes show hyaline globules that can strongly mimic adenoid cystic carcinoma. And when you have cases like that, you can do PLAG1 immunostain. Following validation, it can even be performed on smears or LBC specimens. And if you have a strong positivity for PLAG1, you may be able to make a diagnosis of benign and favor pleomorphic adenoma rather than classify such cases as a SUMP or even suspicious for malignancy, suspicious for adenoid cystic carcinoma. This is another case. You can see basaloid neoplasm with matrix, very thick matrix, and you can maybe even recognize the two cell types, which are confirmed by the immunostain with dual immunostain with CK7 and P63. And in this case, the tumor cells were positive for the RAS Q61R immunostain, but they were negative for those other markers. So in this case, we could make a diagnosis of epithelial myoepithelial carcinoma. And it has been shown, notably in this study, that the use of this RAS Q61R antibodies can be very helpful to support the diagnosis of epithelial myoepithelial carcinoma, even though, of course, it is not present in a significant subset of cases. But when it's positive, that would strongly suggest the diagnosis. This is another case on the cell block. You can see those granular cells with this abundant granules in the cytoplasm, which is already very strongly suggestive of actinic cell carcinoma. For some reason on the cell block, you tend to see those specific zymogen granules much better than on the smears. And this case is already quite straightforward on the HNE alone. But if you do special stains like past diastase, you can further highlight those zymogen granules. And by a combination of immunostains like DOG1 or the more specific NR4A3, you can definitely confirm and make a specific diagnosis of actinic cell carcinoma, as in this case. And there have been now several studies that show that NR4A3 is a very helpful marker, being very sensitive and specific for the diagnosis of actinic cell carcinoma in both cytologic and surgical specimens. And you see here a nice example of the immunostain on ethanol-fixed smear preparation of actinic cell carcinoma. This is another case where on the cell block it looks like some oncocytic neoplasm with a differential diagnosis. In this case, the tumor cells were positive not only for S100 and mammaglobin, but also for pan-Trk with nuclear reactivity. So this is essentially diagnostic of secretory carcinoma. This is another example that was more difficult because the oncocytic cells were admixed with lymphoid stroma that was mimicking a Warthin tumor. So you can see here the differential diagnosis where you can consider the different type of neoplasm, especially Warthin tumor, secretory carcinoma, and even actinic cell carcinoma that can all have very dense lymphoid stroma along with oncocytic cells. And in this case, the neoplastic cells were also positive for mammaglobin, S100, and pan-Trk. But pan-Trk here was more of a strong membranous staining pattern. And they were also negative for all those markers. So that was also diagnostic of secretory carcinoma. And you can see here the corresponding histology, where it's actually a secretory carcinoma with a very prominent tumor-associated lymphoid proliferation that mimics a Warthin tumor or even a lymph node within the parotid gland. This is another case that was more challenging. It is also oncocytic with the cells are much more atypical with mitotic activity, and there is this cystic or necrotic background. The neoplastic cells were strongly positive for androgen receptor and HER2. So the case was classified as malignant, but because the imaging was not too worrisome, the differential diagnosis in this case was in between intraductal carcinoma and salivary duct carcinoma. And the surgical follow-up was actually a high-grade intraductal carcinoma apocrine type that was arising in a background of sclerosing polycystic adenoma, which is very uncommon. And you can see here the intraductal component highlighted by the cytokeratin 5/6 and the P40 dual stain. And of course, the immunostains can also be very helpful to diagnose other less common types of neoplasms that we can sometimes encounter in the salivary gland. This is a very nice example of schwannoma that is strongly positive for SOX10 and S100. So there is no diagnostic difficulties when we have abundant material and we can confirm the diagnosis with those immunostains. This is another example of very high-grade looking malignancies with those large hyperchromatic nuclei, and those tumor cells were positive for Melan A and HMB45, but negative for other markers. So that was a metastatic melanoma. The patient was not known at the time of the FNA for melanoma. This is another case that was more challenging. 68-year-old male with a right parapharyngeal space mass with bone destruction. So it was actually arising from the parotid gland. You can recognize here some normal acinic cell, and you have this neoplastic proliferation of oncocytoid cells with abundant cytoplasmic vacuolization. And the tumor cells were positive for HEP-PAR1, CD10, and also CD34 was highlighting this very peculiar sinusoidal staining pattern. All the tumor cells were negative for those other markers. So in this case, we were able to make a diagnosis of metastatic hepatocellular carcinoma. A few words about fish in salivary gland cytology. There's only a limited number of studies, but those studies have shown also excellent result with the use of fish, especially the sensitivity of 100% to diagnose cases of adenoid cystic carcinoma and secretory carcinoma, among others, based on the presence of those gene fusions that can be assessed by fish. So fish can also be very helpful to make a specific diagnosis only when it is positive. And when you strongly suspect the diagnosis, it's more of a confirmatory test. You can see here a nice example of adenoid cystic carcinoma that looks basaloid on the smear, and the fish confirms the presence of the MYB gene rearrangement. This is another example of a secretory carcinoma that looks oncocytoid, like a stump on the left on the smear, and the fish confirms the presence of the ETV6 gene, which allows to make a specific diagnosis of secretory carcinoma. And to finish, there's now some new markers that are may be available very soon to enhance the diagnosis, and it is especially the chromogenic in situ hybridization for MYB RNA, which has been shown in this study to be even more sensitive than the corresponding in situ hybridization by fish for the diagnosis of adenoid cystic carcinoma. You can see here the comparison, the CISH and the FISH for the diagnosis of adenoid cystic carcinoma. And more recently, there's a new probe for the CISH for MAMMER2 that can be used for the diagnosis of mucoepidermoid carcinoma. That could also be very helpful for cytologic specimen especially in cases, and this is a common a problem with mucoepidermoid carcinoma. Oftentimes, the cellularity is very scant, precluding ancillary studies and definitive diagnosis of such cases. And this is my final slides with the conclusions. So the ancillary studies are not required in most cases, but they can significantly improve the FNA classification using the Milan system, especially when we have a good material. There is no universal standard for ancillary studies. Each institution should define their own goals and limitations based on the available techniques and the resources. And good cell blocks are really crucial in diagnostically challenging cases to allow for the ancillary studies, including the IHC panels. And the ancillary studies keep improving, and they will likely have increasing diagnostic values, becoming more accessible and more affordable. And that is especially the case, expected the case for the NGS and the CISH markers. And the NGS, again, and molecular testing will be covered more in detail in I believe it's the next webinar session in October. And with that, thank you very much for your attention. And I'm happy to take any questions.
Thank you, Marc, very much for a great talk. Unfortunately, there was some disturbance, and now I cannot see any questions. So thank you. There are some appreciation of your great talk and some thumbs coming. So let's wait if there are some questions, but maybe I can start with a question. So
sure.
What is, in your opinion, best approach when you have suspicious salivary gland tumor? What you would suggest? What kind of material collection would be the best option?
I think, first of all, if there is any in your institution, if you have the possibility and the logistic to do rapid on-site evaluation, this is really the start to get the best material out of it and to triage the material for cell blocks. But this is what we have been doing in my institution, because we don't have the logistics to do a rapid on-site evaluation for all those salivary gland FNAs. The surgeon actually does the triage themselves by putting up front with larger core needles the material in directly in cell blocks for processing as a cell block, so we can it's optimized for the use of ancillary studies. And also, as I've discussed, most of the time, we don't really need ancillary studies. So regardless of the type of preparation, if you have a good material, it's not challenging at all to make a diagnosis of pleomorphic adenoma or Warthin tumor. But it is for those cases where the sump cases, the basaloid neoplasm, the oncocytic neoplasms, and a subset of malignancies where the good cell blocks, I really think it can make a difference by allowing the use of all those ancillary studies.